Om Swastiastu, Doctor and friends. We are from Small Group Discussion B1, and today we would like to present our student project entitled Colorectal Carcinoma Screening. Here are our group members, and let me introduce myself. My name is Putumas Ishindrak Sumal, last digit number 003. So the first one is chapter 1. I would like to explain about the background. So before we know about the screening, we have to know what CRC is. So colorectal cancer is a disease characterized by abnormal proliferation of cells in the colon and rectum. And the etiology of CRC itself is associated with genetic syndromes, family history, IBD, lifestyle, and also environmental risk factors. And prevalently, CRC is the second leading cause of cancer-related deaths worldwide. And in 2018, the number of CRC cases in Indonesia was around 30,000 cases, accounting for 8.6% of all cancers. And by the increase of CRC incidences worldwide, although CRC is associated with high mortality when detected at advanced stages, it is also highly preventable. Screening. Screening is the most effective way to reduce mortality. Even though screening methods are effective, they also have limitations. And additionally, many screen-eligible people remain unscreened. With that problem, colorectal cancer is the only cancer where screening has been shown to reduce cancer mortality in both average risk women and men. So because of that, in this literature, we will discuss more about colorectal carcinoma screening to increase our insights about colorectal carcinoma screening. So here's our problem information, objective, and also the benefit of this literature. So next will be discussed by my friends. That's all from me. Thank you.
Swastiastu. My name is Fiona Aurelia, with the last 3 digits of my student number are 125. In this part, we will begin in chapter 2. Now we will start with the definition of colorectal carcinoma screening. So according to Earl et al., colorectal carcinoma screening is a process of checking whether or not precancerous or cancerous growth is present in the colon or rectal. And it is done to people who are asymptomatic. And the goal is to detect and treat the disease as early as possible. Next, according to American Cancer Society, they define colorectal carcinoma screening as a process of detecting or identifying people who are at risk of developing colorectal carcinoma even before they develop any signs or symptoms of this disease. Now, the test itself can be divided into 2 primary groups, namely stool-based tests and visual exams, which will be elaborated more detailed in the next part of the presentation by my friend. That is all from me. Thank you.
Okay, first of all, let me introduce myself. My name is Franciscus Asisi Tokan, with the 3 last digit of my ID number is 092. So here I'm about to explain about the types of colorectal carcinoma screening. So it can be divided into 3 types. The first one is stool-based test, and the second one is visualization-based test, and the last one is blood-based test. So for the stool-based test, it includes fecal immunochemical test, guaiac fecal occult blood test, and also stool DNA test. And for the visualization based test, the examples are sigmoidoscopy, colonoscopy, and also barium enema. And last, we have a blood-based test with the example is methylated cyanide. That's all from me. Thank you.
My name is Nathania Faustin, and I will explain about the mechanism of colorectal cancer screening. Every colorectal cancer screening has its own mechanism. First, GFOBD or guaiac-based fecal occult blood test. This test determines the presence of occult blood in the feces. It utilizes guaiac as a catalyst in the test paper. When hydrogen peroxide reagent is added, it will oxidize the guaiac to a blue-colored quinine. Thus, the result reads as positives. While preparation is needed prior to the test in order to decrease the chance of false negative and false positive results. Next, fecal immunochemical test or FIT. It uses polyclonal antibodies against the globin part of human hemoglobin. The probe that will be used to collect feces are reinserted into the instrument, which has a buffer to stabilize the hemoglobin. There are 2 types of FIT available, qualitative and quantitative. Qualitative tests use lateral flow immunochromatographic cassettes or strips with a dichotomous results, while quantitative tests use automated immunoturbidimetry techniques with a numerical estimation of the fecal hemoglobin concentration. To take this test, patient doesn't need to do bowel preparation. This test is targeted specifically for lower GI bleeding. Third, flexible sigmoidoscopy. It directly visualizes the distal half part of the large intestine. To do these procedures, a sigmoidoscope will be inserted into the rectum. A small video camera at the edge of the tube will send the image to the external monitor. If needed, biopsies can be taken. Prior to the procedures, patients have to do bowel preparation. So it is a quick and sedation-free procedures. It can cause abdominal cramps. Positive results in this test means polyps or abnormal tissues, and further examination is needed to confirm the diagnosis. Next.
Thank you for the opportunity. My name is Anastadio Cristanto with my last three digits on my ID number of 093. I'm going to explain about the next part of the colorectal carcinoma screening, which is the mechanism of action. Okay, the next one is colonoscopy. It is performed with a thin flexible tube that is inserted to the anus and carefully guided up through the rectum, colon, and cecum, and it can go as long as reaching the terminal ileum. It is controlled with a handle and has several instruments. The tip of the colonoscope consists of a video camera and LED to send real-time image to a computer screen, a water jet and air channel to clean the colon, and an instrument like wire loops to remove polyp and taking samples for biopsy. Okay, the next one is CT colonography. It is also known as spiritual colonoscopy, and it is performed with a low-dose radiation CT to produce multiple images of the inside of the body. A small tube called cannula will be inserted to the patient's spleen to insert bowel-relaxant drugs and X-ray dye. And the visualization will be looked at using a special computer program to find any abnormal growth or areas on the bowel wall via two-dimensional cross-sectional image. The next one is methylated serum septin-9. The methylated serum septin-9 is used to detect signs of hypermethylation of the promoter region of the septin-9 gene. This detection requires total cell-free DNA that is extracted from the patient's plasma sample using plasma processing kit, incubated with bisulfite, and amplified with real-time polymerase chain reaction, which result will be interpreted as positive if the quantification cycle was less than 41 cycles. Okay, so that's my explanation. The next part will be explained by my partner.
Thank you for the opportunity. My name is Gekma Saranta with the last digit of NIM number 001. Today, I will explain the procedure of colorectal carcinoma screening. Cancer screening is performed to identify those at risk of developing colorectal cancer. Colonoscopy detects colon lesion. The colonoscope, a flexible tube with a light and small video camera, examines the whole colon and rectum. During procedure, sedation calms patient. It requires dietary and medication changes despite its benefit. It's twice every decade. FIT use antibody to detect human globin in the feces. Unlike most tests, the FIT test doesn't restrict diet or medication. Like non-colonoscopic screening method, it requires endoscopic screening for two-step screening. CT colonography is a radiographic testing method that detects colorectal neoplasia. The procedure requires intestinal prep. Emptying the intestine and rectum before the test improves outcome. Oral contrast medium and a laxative clear the colon. The gas-distended colon is then imagined. Notify staff if a woman suspects pregnancy. The procedure takes about 10 minutes and repeat every 5 years. To remove polyps or explore abnormalities, a colonoscopy is required. The next topic will be explained by my colleague.
Hello everyone, my name is Mariana Benamala with last digits on student numbers 106 and let me continue the presentation. So the next procedure is flexible sigmoidoscopy. In order to help to the colon, the patient receives an enema completed 90 minutes before or is given a laxative the night before the procedure. The rectum, sigmoid colon, and descending colon can then be examined using a standard colonoscope to check for any abnormalities. Repeating flexible sigmoidoscopy every 5 years is advised by the US Preventive Service Task Force. And the next one is capsule colonoscopy. This procedure can be performed by instructing the patient to inject the disposed camera capsule. Prior to having a capsule colonoscopy, patient will be instructed to follow a low resolute diet for 3 days and a full liquid diet for 1 day. Additionally, the patient is directed to consume 2 liter of polyethylene solution the night before and 1 liter in the next morning. The result of the examination using the capsule colonoscopy method need to be confirmed with colonoscopy for a more certain diagnosis and can be repeated every 5 years according to the recommendation of experts. And the last one is septin assay. The examining of plasma samples technique is carried out. The procedure started by taking a 5 ml sample of peripheral blood from each patient, and after the sample is centrifuged and goes through the process of DNA extraction and modification into base uracils using sodium disulfate. Disulfate modified this DNA will be used as templates in order to analyze gain methylation utilizing diagnostic methods. I think that's all for me. Thank you.
Hello, my name is Yofilia Tio Yunus and my last 3 digit of student number is 035. Now I will explain about indications. Colorectal carcinoma screening is indicated for people who have risk factors for colorectal carcinoma. Risk factors for colorectal carcinoma, namely, the first one is family history, especially first-degree relatives, such as colorectal carcinoma and precancerous adenoma. The next one is genetic cancer syndrome, such as Lynch syndrome and juvenile polyposis. The next one is medical history, such as diabetes mellitus and cystic fibrosis. The next one is personal history, such as decreased physical activity and smoke. And the last one is race, higher incidence and mortality among African Americans, especially men. That's all from me. Thank you.
Okay, I will to continue the presentation. My name is Sabrina Putri Donita with the last student ID number 198. On this occasion, I will present about contraindication. Screening methods vary significantly, such as the commonly performed stool-based test. However, colonoscopy requires bowel preparation and carries risk in certain situations. Active inflammation, diverticulitis, or recent colorectal surgery. Suspected colonic perforation or bowel obstruction, patient refusal or inability to receive sedation, and increased risk of perforation in toxic megacolon and fulminant colitis. There are absolute and relative contraindication. Absolute contraindication include patient rejection, recent myocardial infarction, peritonitis, history of colonic anastomosis surgery, or bowel injury. Relative contraindication encompass active inflammation such as colonic perforation, toxic megacolon, ulcerative colitis, Crohn's disease, diverticulitis, or fulminant colitis. Lastly, always consider pregnancy. Colonoscopy should be postponed until after childbirth.
Good morning, my name is Fernando Gosali and my last digit of student number is 036. Now I'll explain about the benefit or advantage of the colorectal carcinoma screening. So, colorectal carcinoma is one of the most prevalent and potentially fatal malignancies worldwide. Fortunately, the implementation of colorectal carcinoma screening programs has proven to be highly effective in reducing both the incidence and the mortality rates associated with this disease. So these are some advantages and benefits of the screening. The first one is early detection and prevention of colorectal carcinoma. And the second one is reduce the incidence of colorectal carcinoma. The third is reduce mortality rate. And the fourth is cost effectiveness. And the fifth is improve the quality of life. That's all from me. Thank you.
And now let me continue the presentation. My name is Gusti Agung Ayu Adinda Fidelia Tresna Putri with my last 3 digits name are 232. So today I will explain about the disadvantages of the screening. The first one is colonoscopy. The disadvantages of colonoscopy include the need for bowel preparation, a higher risk of perforation, and a higher risk of post-procedural bleeding compared to other screening procedures. The second one is fecal immunochemical test, or FIT. FIT has a certain disadvantages, including the necessity for repeated testing. It is also incapable of detecting some types of polyps and cancer. The third one is CT colonography. This procedure is incapable to diagnose polyps less than 10 millimeters, requiring higher radiation, not being able to determine the presence of metastasis in the lymph nodes if the lymph nodes are not enlarged. The fourth one is flexible sigmoidoscopy. Patients are less satisfied with the examination as a result of the absence of sedation or anesthesia compared with the colonoscopy. The fifth one is capsule colonoscopy. The majority of patients with positive studies will need repreparation and a colonoscopy on a different day, since it is challenging to do a same-day colonoscopy. And the last one is SEPT9 assay. The disadvantages of this procedure include lower sensitivity for cancer, inability to identify advanced adenomas compared to other screening tests. I think that's all for me. Thank you.
My name is Idewa Inaraswari Musi with the last digit of my student number is 074. I will explain about the effectivity of colorectal carcinoma screening. The first one is colonoscopy. It has 75 to 93% of sensitivity and 89 to 91% of specificity to detect adenomas greater or equals to 6 mm. The second is fecal immunochemical test. It has 79 to 88 sensitivity and 91 to 93% of specificity. It has high sensitivity to find CRC, which is 80%, and it has 25 to 56% of specificity to detect adenomas. The third is CT colonography. It has 96 to 98 sensitivity for CRC. The fourth is flexible sigmoidoscopy. The screening with sigmoidoscopy alone beyond the age of 50, which is 55 to 64 years, reduces mortality rate of wrong rectal or lower colonic cancer by 60% to 70%. The fifth is capsule colonoscopy. It has 88% of sensitivity and 82% of specificity to detect more than one adenomas greater or equals to 6 mm in asymptomatic patients. The last is SEPT9 assay. It has 75 of sensitivity and 87% of specificity for CRC.
Hello everyone, my name is Idewa Gupta with the last 3 digits of name 072. So right now I will be explaining about the chapter 3, that is the conclusion and the advice. So the conclusion here is that basically the screening for colorectal cancer involves checking for precancerous or cancerous growths in the colon or rectum. And the goal for this kind of the screening is to detect and treat the disease as early as possible. And fortunately, the implementation of colorectal cancer screening programs has proven highly effective in reducing both the incidence and mortality associated with this disease. And then for the advice of this colorectal screening is that the further research and the deeper knowledge is needed in order to improving the future screening of colorectal cancer. That's all from me. Thank you.